And we are now live, Senators.
All right, terrific. So this is Senate Health and Welfare back on January 27th, and we are joined by Owen Foster, who is the chair of the Green Mountain Care Board. Welcome.
Thank you.
And I think our goal today is really to get some insight into the Green Mountain Care Board, because we have new people here, and in addition, some of the new work that you're doing. If we have time, we may ask some questions related to your role as chair and confirmation questions. So we'll just see how that goes. So you brought some stuff with you. Before we begin, we're going to go around, introduce ourselves. I think you've met everyone, but just in case, we'll have a reminder. So Ginny Lyons, chair of the committee and representing Chittenden Southeast.
David Weeks, representing Rutland County, live in Proctor.
Martine LaRocque-Gulick, I live in Burlington and I represent Chittenden Central.
Ruth Hardy from our hometown, Middlebury.
Terry Williams from Rutland County, and I live in Paulding.
So, please introduce yourself for the record, and then we're very pleased that you're here.
Sure. Do we have our slides up? Thank you. So my name is Owen Foster. I'm the chair of the care board. I started just in October, so I've been there a little over 3 months now, around 3 months. I started at the same time as Dave Merman, who's also a new member. Just a little bit of brief background. I'm born and raised in Middlebury. I grew up on a family farm there called Foster Brothers. I have a wife who is a nurse. She does pediatric diabetes, and I have two young daughters, 11 and 8 years old. I think one of them is actually watching today. She's homesick. So we're here today to give you an overview of the care board and an introduction to some of the work that we do and some of the sort of more prescient work that's going on right now that's a little bit different. So if our slides were up, go to the next slide. The board was established in 2011. We have 5 members. I'm the chair, and then there are 4 other members. Everyone has an equal vote, and then we have an executive director, Susan Barrett. We are apolitical, and what that means is we are appointed by the governor, but we are not in the legislative branch, the executive branch, or the judicial branch. We're vetted through a nominating committee. We apply, there's a nominating committee, and only the names of people who go through the nominating committee to the governor can be selected by the governor. And the nominating committee, as some of you know, has representatives from both parties and the community at large. The executive branch is not involved in our decision making. They don't opine, they don't direct us, they don't have opinions that they share with us about our hearings and deliberations and what we should do when we're executing our regulatory function. We have a staff of about 27. And they are experts in a number of different disciplines that relate to what we do. We have public health experts. We have experts in accountable care organizations, hospital finance experts, certificate of need experts. The staff has a large number have advanced degrees relating to the work that we're in. We have PhDs in public health. We have experts in health statistics, data science, epidemiology. I think we have 4 lawyers on the staff, 2 on the board. And we have a PhD in community development and applied economics. And all this background and experience is really useful to educate the board and inform us in our decision-making process. The board itself is a bit diverse in terms of our backgrounds and experiences and the viewpoints we all bring. 2 of us are from Vermont, 3 have made Vermont their homes. We have an economics PhD from Middlebury College, she's a professor. We have Robin Lunge, who's a healthcare policy expert. She was involved in some of the earliest reform efforts in the state. She's also an attorney by training. Dr. Merman is a practicing emergency room physician. He really brings great clinical expertise and practicality to some of our decision making. And then we have Tom Walsh, who's a physical therapist and a PhD in health policy and clinical practice. So we can go to the next slide, Jada. These are some quick facts about what we do, and we'll get into some of this a little bit more granularly, but there are some things that are unique about us, despite including not being part of the executive branch. And one of those that is transparency. And what I mean by that is how we do our work. So Vermont has an open meeting law, and the implications of that is that for the board, we can't meet in a quorum. We can't have three of us together talking about substantive issues relating to our work.
We're familiar with that.
Yeah.
Yeah.
Yeah. It's one interesting because I don't know where anyone's gonna come out before we get into a hearing. I don't know what their questions are. I don't know what their notions, what they're thinking at all, really, until we get into the hearing. And the second part that's interesting about that is the public is allowed to participate. They come to our hearings. Not only do they come to our hearings, they can submit public comment and letter to us during a public comment period prior to hearings. Then during hearings, they can actually speak up and share their opinions. And they do. So at the end of the session that we may have, we call for public comment, and I have a little board and I can see hands raised and they go up. And it's fascinating because some of the public comment is really spot on. It's sharp. It's things that we didn't think about, the healthcare advocate may not have thought about, the party before us didn't think about. Vermont's unique in this way. We have all these healthcare policy experts kind of sprinkled throughout the state and these advocates, and they're almost like their own little think tanks. And they write me, they call me, they send us stuff, and it's really, really, really important and helpful to what we do. A lot of times it's things that we haven't really considered. The other thing that we do on transparency is we're reinstituting our practice of having traveling board meetings. So we have them most every week, board meetings, and now we're doing them out in the community. So we're not just in Montpelier or Burlington. We're getting out. We were in Rutland, December 5th or 6th. I found it incredibly impactful. I went to a treatment facility that helps people that are suffering from use disorders. And we learned about how they're treating their patients. It's really an impactful meeting for me. I asked them, what do you do if you have an increase, right? And a lot more patients. They said, we don't know, but we'll do it. We'll find a way. The people who tell you how they can do things, not why they can't. And I thought that's really neat. We also met with a transitional housing center, which is important in healthcare when you're going from a hospital and you're trying to get somewhere else. And we also visited the emergency department. So that's something we're doing. We're trying to get into the communities. We're hearing all the voices. That's important to me. And that's part of our transparency. We have three major buckets: regulation, data, and then I guess what some people would call innovation. And we'll get into those. But Julie, you can go to the next slide, please. This gives you a sense of what we do and do not directly regulate. As you can see in the small green bubble, these are the things we have direct regulatory responsibility for. It includes health insurer rate review, certificate of needs that hit particular thresholds, hospital budgets, and ACO oversight certification. And then outside of the care board, you have these other things, including federally qualified healthcare centers, independent providers, like primary care providers or independent surgeons or practices, urgent care centers, out-of-state providers, Medicare Advantage plans, Medicaid and Medicare themselves, and self-insured plans. Those are not things that we review in our regulatory process. But our decisions can have collateral effects and impacts on the healthcare world at large here. So we need to be very aware of what's going on in these other areas so that when we make decisions, they're not siloed. An example of that is if we make decisions on hospital budgets, that can have an impact on the affordability of insurance. And those insurance rates are paid for by people that work at independent practices. And so if independent practices are struggling financially, and we allow for large increases in costs for insurance, all those people at that practice have to pay that increased money, right? And if there's not sufficient services at independence, long-term care, mental health, whatever you have, that may influence the hospital budget request because they can't put people or transition them to different care settings where maybe they should be. And so we might see that in our hospital budgets. Go to the next slide, Julia. And Caroline, we have 1 hour, is that right?
Yeah.
So
Yes.
kind of keep you on
Right.
track. In 2022, we reviewed 14 hospital budgets. This happens in the summer. We had 2 accountable care organizations, one large one, one small one. We reviewed 11 health insurance premium rate filings, and we had 7 certificates of need that we reviewed. The next slide. It was a unique year because of the financial challenges and sort of the continuing pandemic issues. In 2023, for fiscal year 2023, the Green Mountain Care Board approved net patient revenue. It's the total amount of revenue for patients that a hospital can get. System-wide, all our 14 hospitals, $3.27 billion, which is a 10.1% NPR increase over the prior year. If you look at our statute and how we're supposed to do our work, there are principles set out that we're supposed to consider. And some of those big ones are affordability, access, and quality, right? And this is the tension. For access, you need more money. For quality, you need more money. But people also need to be able to pay for healthcare. And if they can't afford it, that also hurts access. When people can't pay for care, they delay care, they avoid care. So our challenge is to make sure that there's sustainability, not just amongst the hospitals, but we need to be aware of the independent practices and primary care providers too. And ensure that people can pay for insurance and get care. So that's the tension that we have. It's not walk the walk. And we'll have some data on the healthcare landscape here in Vermont that I hope is informative for everybody. But where we are right now is costs are extremely high. They've gone up significantly. Hospital finances have gone down and are in challenges. Same with independents and primary care providers. And access is in a troubling spot. We have wait times that are unacceptable. So while costs have gone up and we're supporting hospitals more and more financially with huge increases, we're actually seeing hospitals having financial challenges and access challenges. On the next slide, this is our overview of the insurance rate review that we did last year. Again, we had 11 insurance rate filings, and these are just some data points of what was requested by the insurers and what the Green Mountain Care Board approved for individual and small group plans.
I'll ask it.
So just, you can see the data, but it's 24% for MVP, the Care Board approved 19.3%. For Blue Cross small group, it went from 15 down to 11. And then we had our ACO oversight. We certified a new ACO, a Medicare only ACO, and then we reviewed the budget of the larger ACO, One Care Vermont.
Just to clarify for new members of the committee that your rate review is after actuarial analysis is done at the Department of Financial Regulation. So you're not actually establishing the rates, but you're reviewing what the department has done and then the private payers have brought to you.
So
Or maybe I have.
DFR issues a solvency opinion. They also regulate insurance companies, and they give us an opinion on the solvency of because you need them to have enough money to pay for the care that people are expected to have. And then there's actuaries for the insurers and for the Green Mountain Care Board that we employ, and they do analysis on expected costs. And we have someone with Blue Cross here, so they can fill me in if I'm wrong. But we set the actual rates that the insurers charge for those plans.
Would it benefit Vermonters if there were more insurance companies that were doing business in the state?
It's nothing I've studied in particular, but I think as a general matter, more competition and more options are not bad.
Okay, because I only see two here.
There are three.
Three?
There are three.
Cigna.
Cigna,
Cigna.
MVP, and Blue Cross. Blue Cross is a lion's share of the market, and the other two are smaller. But I think competition and options are always good for the market.
We're a small population, so it makes it tough.
And we have significant regulation, right, which
Yeah.
can be a deterrent.
Yeah.
Some people don't have a problem with, but regulation doesn't necessarily. If there's small numbers, small market, difficult market to break into, plus heavy regulation, it can be not as attractive. Right?
As far as bringing other companies in.
I think so, yeah. The other piece of what we do, major regulation piece, is certificates of need, and those are applications essentially to the Care Board to approve capital expenditures and investments. So what we might see are requests to build a new dermatology center, a surgical center, buy a new MRI. There are thresholds that give us jurisdiction. But the reason for that is to make sure that the investments in capital, healthcare capital, is fairly distributed across the state, and that the entity purchasing those things has a demand and an ability to pay for those things. In 2022, we had about $50 million in 7 CONs, certificates of need, that we approved. And in 2023, I anticipate that those numbers will be drastically higher. I think we could see certificates of need with much larger numbers in the coming year. The next big bucket of what we do is data and analytics. So we have three big buckets, and then there's subcomponents, but the next big bucket is data and analytics. What we do on data analytics, we have two large databases that include claims data and discharge data. Claims data, a healthcare claim is just a request for payment, so it might say what the service was, and how much was paid. And that gives us information about what services are being provided, what they cost, and where. And then discharge data may have diagnoses and length of time that people were in a care center. This data is used for all kinds of reasons. For us, directly, we use it to inform our regulatory decision making, right? So we want to know what some of the trends are because they inform us when we make our budgetary decisions. The legislature might use this information to make policy decisions. AHS, EFR, Department of Health, they use this data for various functions for policymaking. And then you have researchers that use this data. I'll give you a couple examples. The wait time study to see, we've been hearing anecdotally that people are having problems getting in to see care that they needed. And so these databases were accessed for DFR to perform an analysis and study to validate those concerns, right? So if you have a problem, you need to identify the problem, you need to validate the problem, you need to understand the problem. And only then can you actually address the problem. So this data helps do all of those things. There's also a study done on lung cancer screening in rural communities, looking at socio-demographic factors and rurality to see if that impacted the timing in screening for lung cancer. And when lung cancer is discovered later, it's more fatal. And there was findings made related to that. So we can actually think about where we need to put resources. And another one that I thought was interesting was a study that was done on suicide. We've had problems with our suicide rate increasing in the state. And so a study was done on these databases that assessed what some markers were that could be indicative of potential suicide risk and what interventions there were, right? So you can see what's working, what to look for, and what works to help stop that problem. So this is very important information that the Care Board keeps. And it's
Can you talk a little bit about how this is distinguished from the data that the Department of Health is collecting? Is there any redundancy here? Because I sometimes think maybe this should all be in one place, like at the Department of Health, and then inform Green Mountain Care Board. And it sounds like, so maybe you could just comment on that.
I don't have much expertise in what information the Department of Health has right now, so I'd have to get back to you on that. I haven't studied myself if there's overlap.
Well, it used to be that the Department of Health collected the data and then informed the what was it called? The Public Oversight Commission, the POC.
Yeah.
It's the POC. So anyway, that would be helpful just to think about that as an issue. In particular, when you're collecting data on chronic diseases and other things that might overlap. But so I'll just leave it.
Those reports you're talking about, the data, is that public information?
It is.
Okay.
I mean, the data, the underlying data is not, but the reports are. And they're on our website. We can send you links to those.
Okay.
All of our reports that are.
I'm concerned about the suicide rate, obviously, among veterans especially.
I don't know if there's been a sub-study of veterans in particular. I don't know the answer to that, but we can send you the next report.
And that's something that the Department of Health may have, so it'd be interesting to know the distinction between what you're doing and what they're doing.
I think there's a difference between the data the Department of Health has versus their data, and there's a different purpose for them. Because I think a lot of the data that the Green Mountain Care Board accesses involves the finances end of it, whereas Department of Health is about health outcomes. And sometimes it overlaps, like Owen just talked about.
Right, so but the question is, where is the overlap and is it effective to keep it all there? Is there redundancy? I'm not suggesting that there isn't a good reason for the data collection here, but what's the match with that and what might be the most efficient way to collect and use data?
There's also health data at Vital.
Yeah.
And a number of other places with
Yeah.
these electronic medical records.
Yeah.
Data has become much more robust.
Yeah.
So there are a number of places that have this type of information. If we go to the next slide. This is from our website. We have all kinds of data available, interactive maps, interactive things. So what you can look at, what this shows here, is a snapshot of the top payers in Vermont and how many members there are in the claims, right? So you can see Blue Cross Blue Shield of Vermont has 425 members, or sorry, claims. Vermont Medicaid had 398,000, Cigna had 296. And you can see the distribution between commercial Medicaid and Medicare, right? If you go to the next slide, Julia. This is from our health resource allocation plan. I go on this sometimes. I find it pretty interesting. You can actually see how many PAs and there are per 100,000 people in different communities. So in the Burlington area, there's 11.5 per 100,000 people. In Randolph, that number's 24.5, Rutland's 22.7. So you can see how different areas are doing with the number of providers they have. There's all kinds of different things. Percent of underinsured people in the community. You can just click on that, and then you can get it by each community. Percent of adults with health insurance. Again, you can see it by every community you have. And then here, this is from our expenditure analysis, which measures how much money is being spent and where. You can see where the money comes from, out-of-pocket health insurance. Within that, how much is commercial, Medicare, Medicaid, and where the money goes. Hospitals versus physicians, dentists. You can see how we distribute the resources we have within the state. Go to the next slide. I want to talk a little bit about the healthcare landscape here in Vermont, which is something that we all need to pay a lot of attention to at all times. We spoke a little bit earlier about some of the challenges hospitals are having financially. One of the key metrics we look at is called days cash on hand. That's just essentially how long the hospital can operate based on how much money it has. There's debates about what the right level is. Too much means they're charging too much and they're holding too much. Too little means they're in financial trouble. But like a rough benchmark, rough is around 180 days. And so here we are in 2018. A means actual, P means projected, and B means budgeted. So you see it was up around 180 in 2018. And then in 2022, we're down under 150. That's a troubling trend line. While 20 and 21 go up, those are a bit of an anomaly because there's significant cash infusion from the feds, right? So that propped up those 2 years. And as we've seen that money go away, we're back on the decline. And budgeted, well, sometimes you can budget something that doesn't come to fruition. So I wouldn't take that number as gospel. And I think if you take out the little bit of anomalies, this is really, your trend line that you actually have. And it's not a good one. The next slide, another metric we use is operating margin. And that's essentially how much money is being pulled through from the revenue into profit. It's another key metric by which you look at and evaluate health. Again, debatable what the right level is. 3% is sort of a rough number. I think hospitals would say they want higher, but again, that relates to how much they're holding versus how much they're charging. You don't want too high. So there's debate, but certainly above where we are. So in 2018, again, we were at 1%, that's low. And then today, we're projecting, and we'll have actuals pretty soon here in a couple of weeks, I think, we are down at -2. That means on their operations, they're not pulling through money to profits. This is system-wide in Vermont. And again, you see a huge anomaly in 21 with the jump with the federal infusion. And in 23, you see budget numbers, which might be a little bit optimistic potentially. I want to say one thing about sustainability, because in the media and just in the circles I walk in, maybe because of my job, we hear a lot about hospital sustainability, but there are independent practices and primary care providers, and they are struggling too. So I don't have data on them. They're not in my regulatory sphere, at the care board. But if you don't have enough primaries, you have problems at the hospital financially. If you don't have long-term care, you have problems at the hospitals. If you don't have mental health, you have problems at the hospital. That hurts their budget and our finances for all of us to pay for it when there's not adequate primary and independence, right? They also can be cheaper and they also can be more accessible, right? So I don't want the conversation about hospital sustainability to necessarily drown out all the other infrastructure we need for a good, healthy economy. The hospital finances are critically important. We need hospitals. We need them financially safe, but we also need all these others too. Go to the next slide. Before I came to the care board, I'd read a lot of press, sort of, in some ways, criticizing the board's budgetary decisions or scapegoating even the care board for its budgetary decisions, suggesting that some of the care board's decisions were, in part, responsible for some of the wait times or hospital financial challenges. And so this week, I pulled the data on what was submitted to the care board for budgets and what care board actually approved. Because I was curious if that was true. Have we harmed, through our budgetary decisions, access to care? Have we harmed hospital finances by our decisions? Because if we have, we should know it. Everyone should know it. So this chart shows the last 5 years, every dollar requested in the hospital budgets by every hospital. And below that, we have every approved amount that was approved by the care board. So there's a couple things that are significant here. One, in 2019, the hospitals requested $2.6 billion. In 5 years, that number has grown to over $3.2 billion. So Vermonters are supporting our hospital system by $600 million more in the last 5 years. That's a significant amount of money for a state of 650,000 people. The health network itself has gone from 1.5 billion to over 2 billion. If you look down here at the bottom, these are the approved amounts. They are very, 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 very close to what the hospitals actually requested. So the growth is about 25% in approved for the system by the care board and about 29.5% for the network. If you go to the next slide. I'd also heard complaints or concerns that the care board was not treating the hospitals equally, that we were favoring small hospitals over the network. And I wanted to know if that was true. And so I actually pulled the data on the percentages of the budget submitted and what we approved. And what you see in the last 5 years, this column here, 2019 to 2023, has the aggregate of the amount, the percentage the care board approved of the budgets. The care board in the last 5 years has approved 99.7% of what our hospitals have requested. And for UVM hospitals, the care board has approved 99.78% of what UVM requested. And for non-UVM, the care board's approved 99.56% of what's been requested. So.
So Chair, is that okay if I ask?
Yeah.
You may not be able,
Okay with
if it's okay with you, yeah.
Mr. Foster.
Okay, great, we all agree.
We all agree. I just didn't know if you wanted to be interrupted.
You may not be able to answer this, but any sense as to why there was this this perception that is obviously quite inaccurate? I mean,
that perception is what I've gathered from reading the newspaper over the last 5 years in this state and kind of being around the healthcare world myself, and from my travels here in 3 months as a care board chair. It's something that's been shared with me as a criticism, and we need to look at our criticisms. I don't think that perception is accurate. It doesn't look like it's accurate to me. I don't think the care board's responsible for the wait times, the staffing shortages, the hospital financial challenges. It's hard to see that when we've approved the budgets to this level.
Right.
So I don't really have a great answer. And then the chart on the right, so when we do a budget, and I haven't done one myself, so I'm not that intimately familiar with the process yet, but we have breakouts for how much is going to be approved for commercial, right, versus TRICARE, Medicare, Medicaid. And these here on the right are the amounts that are requested for commercial that the care board approved, right, which is a different segment. And on commercial system-wide, we've approved 99.14% of what was requested.
Six Senator Weeks has a question.
Just have a kind of a curiosity question. So coming out of the world of corporate contract negotiations, it's routine to ask more or to present more than you actually need, knowing that everybody feels good when you get chiseled down and everybody essentially walks away at a kind of a stabilized point. And I don't know if it's applicable to this field, but we just did it knowingly, every year, every contract. But so, and again, I don't know if you can comment on it, but is there a sense that, you know, there's a bit of gamesmanship that everyone comes in high? Because when going back to like, and don't go back, but the third or fourth slide, it looked like everybody felt good about this is what we received in request, and this is what we actually authorized. Well, from my perspective, that's what I'd expect to see every time. And down, there were like 4 or 5 examples down the board, and they were all losing that from submission to acceptance. They were all losing that 20 to 25%. It's just what we get all the time. A different field though. I'm just curious.
Very good question. And I am and was a lawyer, and I'd make demands from companies for settlement. And I would put a little more on there than I actually wanted to. That's part of negotiating. I couldn't answer your question accurately in terms of whether that's happening here. I don't know the answer.
Right, okay.
I've never asked them. I will ask them when we have hearings. I'm going to ask them that. I think it's important to know. And, you know, does this mean we're approving it at too high of a rate? If there's fluff, then potentially. Or are they submitting really accurate, really good budgets that should be approved to this level? I don't have an answer for that sitting here today.
Yeah, I didn't expect you to have an answer. I just,
Yeah.
it's just an observation.
It's a hard question. It's a good observation. I think it's something we should consider. I think we need to be honest about the data, and we should consider. Perhaps hospitals are putting in lower budgets because we have this process and they know they're going to be scrutinized. So I don't know. I really don't know the answer, but it's a good question. I think it's an important one.
I have a question, then I have a question.
What kind of problems do you think were created because of the infusion of more federal money in those 2 years? What I've seen at the local government was, we didn't have a plan on how to use that. We got it. And if you don't use it, you're either gonna lose it or you're never gonna get it again. So is that applicable here?
It's hard for me to answer just because I haven't been there more than 3 months and I wasn't part of how that money, that federal infusion was used. I understand the point. I don't know the answer to that. I apologize.
Go ahead.
No, I was just gonna weigh in a little bit. I mean, a lot of the money that hospitals got were to cover the emergency expenses they had from a public health
Yeah, they
emergency.
really needed it.
It wasn't like the money that towns are getting that is just kind of oh, here's some money because, and you decide what to do with it. I mean, it was literally to keep the doors open during a global health pandemic. And I think a lot of hospitals would have gone under without it.
As well as long-term care centers.
Yeah, absolutely. At all healthcare
And there were
providers.
stabilization funds for private practices. So there were a lot of dollars that were targeted to make sure that the healthcare, business of healthcare stayed alive during the pandemic. It was huge.
So I think, I don't have this data for you, which would be relevant, but the volume of patients that hospitals saw really got decimated by the pandemic. And so when you lose all those patients, their finances were a real shambles. And so that federal infusion helped stabilize, and we needed the hospitals for access for pandemic related treatment. So, you know, were there some adverse? I have no idea if there's adverse consequences, but certainly it was very significant to keeping the doors open when those treatments went away, right? And we have financial problems at the hospitals. Where would they be without that federal money? They would be in a worse financial position for sure.
So while you're talking about the influence of hospital budgets on other, private practices or community services or long-term care, Act 167, in particular Part 2, where there's a needs assessment to look at what are the community-based needs and then link that in with both Green Mountain Care Board and AHS. I think that work, and maybe you can talk about that a little bit later, the work that's going on there.
I can touch on that for sure. That's a little bit later. So one point on this is just that we have provided pretty significant financial support to the hospitals, which is important to do. We want them stable. I think it's also important I wonder if independent practice and primary cares have seen a similar level of increase in financial support. I don't know the answer to that. But it's something to think about. That's a policy issue. That's not something that's directly in our sphere at this moment, but it's a question of, for policy, where should the money go? How should it be distributed? Should it be equal? Should the independents get more, primaries get more, hospitals get more? How do you allocate it? Those are questions I think should be kept in mind. So we can go to the next slide. Affordability is a challenge for too many Vermonters. This is from the exchange, the health exchange, where people can buy health insurance. And we pulled the data from 2018 to 2023 so we can see what's happened to costs for people purchasing on the exchange. Health insurance costs are very complicated, and this slide is not the be all and end all of what costs are. It would take a lot more discussion to really get it exactly right, and this is provided for directional purposes because there are subsidies and they are at different levels and they drop off, and there's different support for people to buy health insurance. So this may not actually be exactly what people are experiencing, but directionally it provides you some information. So for a silver plan, that's from 2018, it was under $20,000. That's a family of 4 purchasing on the exchange without subsidies for a silver plan under 20,000. And keep in mind, most people on the silver plans in Vermont at this moment do get subsidies. So the cost would be quite a bit lower for the majority of people on silver plans in Vermont. But in 2023, that went up to nearly $30,000. For a platinum plan, it went from $25,000, it might be around $38,000 for annual premiums if you're paying in full for a family of 4 purchasing on the exchange. So you have the premium and then you have the out-of-pocket, right? We all pay out-of-pocket and then you get maxed out. And this chart here on the right shows what those costs have done on the exchange without subsidies. And you have silver plans were out of pocket around under 14,000. Now they're up around over 18,000, right? And platinum, you pay a lower out of pocket because you're paying more upfront. Those have held a little bit steadier, but have also increased. But if you add those two numbers together, so if you max your out of pocket, which many families do, my family does, you're paying a lot of money. And keep in mind, the income levels. So this isn't necessarily just because of hospital budget increases. It's not. There's so many different influences that go through. It's not a dollar for dollar thing, but certainly the support that we've given to all the healthcare systems, it's important to keep in mind affordability. Affordability, we talk about access and having doctors, but affordability really is an important part. The Healthcare Advocates Office has great data and analysis on the percentage of people underinsured, the number of people avoiding care because they can't afford this. Go to the next slide, Julia.
Yeah, the budget center. No.
These are just a couple of quick data points and resources on that issue about affordability. We have a very low uninsured rate in Vermont, which is excellent. We're only 2.6% uninsured. Our underinsured rate, which relates to people's ability to afford the costs, is quite a bit higher. It's around 38%. And you have to check the definitions in the reports. It's a little bit more complex in the spheres. And the Healthcare Advocate, as I mentioned, had a report about surveying how many people are raising concerns about their ability to make payments. They have medical debt, significant medical debt, credit cards, home loans, just debt. They just owe money. And when you do that, are you going to go to the doctor? And when you delay care, your problems get worse, right? They don't get better. Sometimes they go away, but a lot of them get worse. That's a lesson I've learned in my life over and over. Go to the next slide. I'll touch briefly on some of what we call innovation. And this is really guided. I think of this in terms of a couple major buckets. The first is Act 167. There's a couple things that we're doing. One is we are collaborating with AHS on the new all-payer model agreement. There's negotiations with the federal government on what that will look like. And what that is essentially is changing the way healthcare is paid for to a system that aligns incentives a little bit better. There's a concern that when you pay fee for service, it incentivizes high cost care. And if you fix to measuring quality and the health of your population, it will lower healthcare costs or curb the increase. So the Green Mountain Care Board works probably daily. I work very frequently with AHS on these issues. We collaborate with them, we share data with them, we share strategies with them. We have working group meetings every week on the issues that we're working on. But they're the lead on that, and they're lead negotiator. We work with them, have a really good working relationship, and everyone's spending a lot of time on that. The other piece of innovation, as you touch on, is the sustainability work, which was passed last summer for the Care Board. We're leading, and AHS is collaborating with us on working to evaluate what communities have and what communities need, right? So a lot of communities are seeing an inability for people to get the mental health that they need. So we're doing a deeper dive and more granular study of what communities need and where the gaps are so that we can have the right resources available to our patients throughout the state of Vermont. The other thing we have that I guess would go in the innovation bucket is some advisory groups, and we meet with them and they give us information about what they're seeing. We have a general advisory group, a primary care advisory group, and a prescription drug advisory group. And we meet with them and they provide us information about what's actually going on out there. The general advisory group is required by statute, and the others are ones that we're permitted to create at the board's discretion. These again help inform not just our regulatory decisions, but also policy makers and the public. And they're incredibly valuable to the work that we do. But I'd put that kind of in the innovation bucket as well.
Owen, I just wanted to make one comment. I think that, I can't speak to the other two, but I think the primary care advisory group is really underutilized and has been really underutilized. And so I would just encourage you to really beef up the work of that and your consultation with them, because last year when we were talking a lot about primary care, it was clear that that group wasn't as active as it could or should have been, and that maybe they weren't getting heard as much as they could or should have been.
So in terms of cadence and substance?
Yeah, that was my impression. We never had them in here, but it seemed to me that there's an opportunity to use them more.
I appreciate that. Yeah, I think that we do have a problem with primary care in this state. I can't get a primary care provider. Since I've been the chair, I've called 8 places trying to get a primary care provider. 8. You don't have one either. There's a number of employees at the care board that don't have.
I got a nurse practitioner in my practice.
Yeah.
You saw that other slide that demonstrated where you have different primary care types.
Right. In Chittenden County in particular and other areas with different levels of need for primary care providers, we have I think a particularly acute challenge with it in Chittenden County right now. There's been a big influx of folks moving here during the pandemic, but it's a problem throughout the state. This is some brief history on hospital sustainability. The finances and sustainability of hospitals has been something on the care board's mind for a period of years. This is a little bit of a timeline on some of the reports that have been done and some of the requests that have been made relating to studying that issue, which is now picking up. We're really in the midst of it. I know you heard from Sarah Kinsler and Sarah Lindbergh yesterday.
Yeah, she did a good job yesterday of teeing that all up.
Yeah. All right, so we can move on from this. I want to touch briefly on some of our areas of focus. Some are the statutory big obvious ones. We're doing a review of our hospital budget process. I think it's important for the hospitals and everyone to do a little self-reflection and make sure we're doing things right. I think it's important for the care board to do that too. And this is something that we are spending a lot of time on. We've heard complaints that our budgetary process, particularly the need process, is cumbersome and administratively burdensome and costly. I will note that it's not often that regulatees like how regulation is done, but we need to hear that, we need to understand it, and where there are ways we can make it more efficient and surgical while still having the same quality for Vermonters, we need to do that. And so we're doing that right now. We're Also, again, I mentioned the collaboration with AHS on the all-payer model. We're focusing also on access to primary care and affordability. We're doing that through a series of hearings we're having and studies that we're doing. I'll say a little bit personally about things that I'm interested in. I'm very interested in making sure that we're hearing all voices. And I have everyone has historical baggage that influences what they do, and I have some. When I was as an AUSA, assistant U.S. attorney, I would do a case, an argument, a trial, whatever it was, and I would sit down and think I was going to win. And then the other side would go, and I'd sit down and go, oh my God, I am toast. I am losing. And then I would have a rebuttal or whatever. And so the reality is the last voice, the voice you hear, the only voice you hear can really influence what you think. You hear an anecdote, but you don't hear the other side, that anecdote becomes truth.
Reality.
And so for me, just based on kind of that life experience, it's important for me to hear from everybody. We regulate the hospitals, they have lobbyists, they have resources, and so do some other healthcare participants, but so do patients need to be heard, right? So I've implemented a soft rule for myself that some people don't like, but every executive I meet with, I need to go and meet with a doctor, a patient, a nurse, a small business, a healthcare advocate, everyone else. I need to make it balanced. And I do that. So I think that's really, really critical to the work. This last week, I think it's just this last week, I met with the UVM CEO. I met with the healthcare advocate. I met with the carpenter who can afford his insurance. I met with an independent surgeon. I met with, I think, a couple others. So you can see a balance, and that's a soft rule I've implemented for myself and that I've encouraged others to have, because I think we can't really do the regulatory process effectively without that. It's really, really important. I guess the other priority I have is the office and the people. I know you've met a few of them. They are phenomenal. They're really talented. And I need to make sure that they have satisfactory and productive careers and opportunity. So that's a little bit more internal. I was with Dave Merman, who's a new member, and we were sort of laughing and saying, did we sneaky walk into the most productive office in the state? Like, these people are amazing. We just couldn't believe how good they are. So we have an obligation to help them. Next slide. This is just on some reports that we have. You'll see we had a number of them just come due, and you can access those. They're sent. The legislature has them, and a couple others. Go to next. These are ways your constituents can contact us and be part of that process to inform our decision making. You can see these here and some additional links or resources. And that's all I have for today.
That's a lot. No, thank you. That's a good insight into the work that you're doing. I do have two questions. One is related to the HRAP, and then I want to go back to Act 167 very briefly. So if you could talk about what the HRAP is, because it was on one of your initial slides, Health Resource Allocation Plan, and what does it mean to you?
Yeah. The HRAP is a study we do periodically that provides an assessment of what resources there are around the state. And the inventory is essentially the services available, the number of physicians, PAs, and the type of equipment that's distributed throughout the state. It relates to some of the work that's being done with 167. So that's sort of more of an inventory aspect. And then 167 work includes more of a needs assessment and look. And that is one of the things, screenshots I showed earlier, that you can access some of the data from those interactive maps. It's from the HRAP. I'm sorry.
That was it. I mean, and you linked it in with 167. I was going to ask you to do that, so that's helpful. But, and then one of the issues that we're faced with a real problem in our healthcare world. We just talked earlier about substance use disorder, mental health. You've mentioned emergency rooms, primary care, long-term care. And how do you see the board's work related to all of these really difficult problems that we're facing?
Yeah, it's a great question because we do have authorities that are set out by statute that are limited. and that's what we do. But there is this universe that we have to think about. And so one of the things where any organization evolves in how they do their work and how they go about it, hospitals do, legislators do, baseball teams do. And we are working on, in our hospital budget review process and some of the other things we're working on, we're considering that broader ecosystem and how our decisions impact all of it. But we don't, at the care board, because of our limitation and what we're assigned to do, we are focused on those things. They certainly get more of our attention because they're things we have to decide to deliberate on. But we incorporate those things through the hearings, through the meetings, through the HRAP. And so they are part of our process. I think they might need to be a greater part of our process. There might be room to improve on that.
I know, because what we hear is, oh golly, there are 50 elderly patients in the hospital and there's not a bed for them out in long-term care. So how does that, that fits in with your budget decision? And similarly, we've got mental health crisis and folks are in the ED, and what's out in the community and how does that relate to the hospital budget process? And then we have kids right now waiting for transgender discussion. They have dysphoria and they need counseling and they need support. And at the same time, we have eating disorders that are going on. And there's a waiting list out there for kids who are in dire straits. How does that relate to the budget? So for us, we need to solve all these problems. At the same time, it's putting pressure on the hospitals trying to solve those problems, and then they take it right to you.
So we can't, in our budgetary decisions, say, hospital, you get a lower amount, send that money to
Yes,
create
right.
long-term care. We don't do that. We don't have the authority for that. That is well beyond what we do. So I don't think that's something in our universe,
Yeah.
right? We can't come up with money. That's not our job, not our role. We can't create businesses. We can't invite insurance companies. But so what we can do, given those practical limitations and probably appropriate limitations, is we can just be aware of them and think about them in our budgetary decisions. We can shine a light on some of the issues by having public hearings. But in terms of directly solving those problems, our budgetary decisions, we can't allocate money like that.
I was hoping you'd say you'd solve all those problems.
You might need to get one of the other board members in. They might have a better idea than I do, but no.
Okay, yeah, go ahead.
How often do you meet? As needed, or is there, I'm kind of a glutton for punishment. I'd like to actually sit through one of your meetings.
Oh, yeah.
And that's the best
You
way
can
for
watch
me
all the
to
videos.
experience. I can do it by Zoom or whatever you do.
So there is not a set cadence. There are certain seasons of what we're doing. The next big hearing, One Care, the ACO is supposed to submit a new budget by the end of this month because there's a change in their participants. And so that hearing will be scheduled at some point in the future if they submit a new budget, and we'll review that new budget that they plug in. And then we have rate review. Those will be public hearings. Then in the summer, we got the hospitals, and in the fall, we got the ACOs. But then we have a whole number of others. I think last year we did 52 public board hearings. So they are commonly once a week, sometimes 2 in a week, and then the next, whatever it might be.
And we're actually, we couldn't go to the last meeting that you had with some experts, I think one from North Carolina. We couldn't go to that one, but I think when the next one happens in the morning, we might schedule that in a little bit.
They're typically Wednesday afternoons around 1, typically, but depending on what it is.
Yeah.
First of all, you mentioned that you thought you were gonna see an increase in CON requests, and I'm wondering if you could speak to that a little bit, what you're expecting. And then, given that your focus is so singularly on hospitals, do you think there's an argument to broaden your focus so that you would be looking at long-term care facilities or mental health facilities or other of the major healthcare facilities in the state?
So those can come in to the certificate of need process.
Right, yeah, I know that, but I mean, for the budget process,
Do I think we should regulate those things? Is that essentially the question?
yeah, more or less. Mine was a little more indirect, but yeah, sure.
I haven't really done an assessment of what the pros and cons are of that. I know there is burden for those entities that we regulate, right? Like it takes a lot of time to submit this information, to come in for a public hearing and do it. So for an independent practice, that is really difficult.
Oh, not the independent practice. I mean, the long-term care facilities, or the mental health, or home health and hospice facility, those kinds of larger entities.
You know, there are pros and cons. I think one of the big pros would be that those issues are more in the public. The challenges they have, the needs they have would be more, there'd be greater public awareness, and the board would be more informed of what they're seeing, right? Because you got to worry that we're getting a little siloed in just what we're seeing. So that would be a benefit. The con would be you're adding burden, administrative burden, people don't like it, and there's some risk of that. So that I think it.
And, yeah. And
And
there
then
are
what
other,
about the CON request that you're expecting?
So I've heard rumors, I don't want to share them in a
okay.
public hearing, that there's going to be some fairly large ones
Got it.
down the pike. And also, if you look at COVID, a lot of people delayed capital improvements because of the financial challenges, although the financial challenges have not abated. So that's something we need to consider when we get these. If the finances are not strong, should there be major capital improvements? How do we balance that need for those things with a difficult financial position?
Senator Weeks.
Yeah, just a curiosity question. So, given the escalating cost of healthcare over time, and given the increasing percent of public funds used to support the medical system, I'm wondering if there's an analysis from within your staff about how the cost of medical care is resulting in the improvement of health overall of our population, whether it's Vermont or the nation or what have you. Just a fundamental, given focus on one, is it resulting in types of positive results in the other?
Are we getting
Are
something?
we getting our bang for the buck? Yeah.
Exceedingly complex question and difficult to analyze. Vermont and nationally, we've done a much better job of including quality metrics and actually paying based on quality. I think we're certainly in a better place than if we hadn't put in the money, right? I mean, you would have hospital closures, you'd have more independents closing, you'd have access problems. In terms of like how much are we get the ROI on all these investments, I'm not aware of a clean, easy study that's been done. I can ask our staff what we have on that. But it's an appropriate question. Are we just sustaining by increasing the costs? Are we just making things less bad by increasing the costs? Or are we making them better?
Or better, right? I mean, it would be great if we had a metric we could show our constituents, hey, look, here's the data. It's, public, funding public health.
Gotcha. And we have seen some data indicating a lower rate of growth in this state because of the work that we've done. And so that would be helpful for us to get maybe I think we have some slides somewhere in our slide decks that we've had this year on that. So it would be helpful just to maybe get a look at that. Maybe your staff could pull something.
Yeah, so 2 points real quick. One is if you make things less bad, you're making things better, right? So if they would have been worse, but for the investment, that's an improvement.
Yeah.
If they're better than before, that's even better. In terms of the curbing the costs, there have been cost curbing of the costs here in Vermont. I've seen a slide where the growth rate in costs statewide, I think it was around, don't quote me, but it's around 6.5% or something. I think it was pre-care board. And then since the all-payer model or the care board, I forget which, it's curbed out around maybe 3.5-ish.
So, yeah, we'll look at that because that we hear that we're doing so well compared to the rest of the country. It would be nice for us to actually have that in our hands. The other question I'm going to ask, and I'm not going to ask you to answer it, but because we have another issue that we want to pick up here. But the question is about now Blue Cross and Blue Shield is pulled out of the ACO, and your assessment of what effect, if any, do you see that having on our primary care practices in particular? So it seems to be a huge issue.
So we haven't seen the revised budget yet for OneCare and whether or not they have opportunities that they're going to pursue to lessen the impact of Blue Cross pulling out. And we haven't heard the final word, or I'm not aware of what it is from Blue Cross and how they're going to continue supporting primaries. I've heard that they're going to pay for 6 months and reevaluate.
Yeah.
And we're going to look in the new budget we get from OneCare to see what they're doing. And once we get that, the staff will do an analysis. We'll see if there's other things we can do or we can require to be done. But I'm hoping that OneCare comes up with solutions to that problem and that they're funding those primaries in full.
Okay, and then the other question that probably you're gonna, I mean, we'll see the answer later, but is applying risk and adding risk to OneCare, which you have done, and which is unusual, I think, across the country, but I don't know how unusual.
I think it's actually usual. I think it's
It is?
typical. Yeah, I think it's certainly if mature ACOs or high performing ACOs, that's what you see. You see risk. We applied a very minimal amount. I think OneCare before had almost no risk and now they have around 10% of the risk. If you think about it logically, what we're trying to do is get the ACO to perform better. So people like Blue Cross want to be part of it. And it's their programs. They're the network organizer. If they design the programs, they should be accountable for their programs and whether or not they're working. And so what the care board did was put a small amount of risk so they have some skin in the game. You hear a lot of public comments, see a lot of public comments and proclamations that it's working. So it's sort of hard to reconcile those statements with history of actions trying to limit the amount of risk they take and threatening to pull out of Medicare should they have risk, right? If you have confidence in what you're doing, in your programs, risk is good because there's reward. And historically, OneCare has taken on $36 million risk, 2%, 2.5% of a $1.4 billion budget. That's small.
Right.
High performing ACOs take more, and then you get more upside. And so we want to see the kind of confidence and structure that allows them to get more money for their providers and save Vermonters more money. So that's what we did.
Okay, thank you. That was a good answer. Appreciate it. And so I think what we're going to do, what we'll do is we're going to invite you back for a short confirmation hearing. And we'll have questions prepared. We don't have your resume with us as yet, so we'll do that. We appreciate your coming in and sharing with us what you are doing at the board right now, where the board is. So we'll come back another day to grill you. Okay. Thank you very much. Appreciate it. And what we're going to do now is, I think Katie McClin is around somewhere, but we want to look at H1 with an eye to there. No, she might be coming downstairs. She was testifying somewhere. Alex, can you maybe check and see where Katie is?
I'm sending her a message right now.
Thank you. Thank you so much.
It's a pleasure.
Great. You'll be back.
Should we go offline while we're waiting for the commotion?
Alex did send us his resume, I think I saw it in my email.
They sent it last night.
Yeah.
Okay.
We're gonna hold on.
I have sent it on to the committee.
We're staying live.
Oh, we are.
And we are going to H1. And we're gonna do that to allow us some time before we go on the floor.
I printed the tally.
Oh, good, okay. Well,
Let's see, you're all.
Senator Hardy goes.
I'm all over it. I'm on fire. You're on fire today. Well, you both are. We're asking really good,
Friday,
Okay.
I'm taking
We're
all
not
your
on-
you're
data.
asking really good questions.
We're not on break. We are not on break.
I'm just grabbing the bill out
Oh,
of the
no, that's
drawer.
okay.
Sorry. Steady on.
Because Alex told me it should be here.
Okay,
Yes, in that top drawer, there's a folder marked 2023 bills. I think it should be in the back of that one.
Great.
okay.
She's not out here.
That's okay. It's okay.
She's coming over from another committee. She'll be there in a
Yeah.
minute.
Okay.
Yeah. All right, so we've talked about the amendment to the proposal on H1, which is two things, really, a technical correction to the conference committee report from last year on the conflict resolution. Here she is. Okay, Katie, why don't you come up and join us while we talk about the bill and get ready to consider a vote.
So it's S2, correct?
H1,
Oh, I don't,
we'll find it later. That's not, it's not.
It's not relevant?
It's not
Oh,
essential.
I think only S2 is in there, Senator, so we'll have to
Yeah,
get
okay,
another
yeah,
copy
no
of
wonder.
H1.
that's okay, it just means I'm.
Yeah.
Okay, got it.
We're good. Okay, so Katie, remind us what H1 is
Sure.
briefly, and then we'll entertain a motion and discussion.
Sure. Good morning, Katie McManus, Legislative Council. So H1 is a correction bill. It's a bill that pertains to conflict-free case management and payment reform for individuals with developmental disabilities. It replaces Section 6 of Act 186 with a new Section 6 that largely looks at the same issues, but the difference is in legislative oversight. Instead of approval, it requires input from the General Assembly.
Questions for Katie? Looking for a motion.
I'll make a motion to approve H1.
It would be to vote on H1 as it came from the House, to send to the full Senate for a vote.
I make a motion to approve H1 as it came from the House to vote on it
Okay. Send it to the full Senate.
and send it to the full Senate.
That's good. That's good. That's a good motion.
Second.
All right, good. Discussion.
I'm not thrilled by the 1-year delay, but I can live with it. As long as we get them back in here to make sure that they're moving along with their work, just based on what we heard last year, I think it's problematic. to have it.
We'll bring the Disabilities Advisory Council in as well, as we go forward, to make sure things are happening.
Yeah, and I think they told us last year that they could move forward and they haven't, so I'm not thrilled by that. So, but I will
Okay.
still vote for it.
Not everybody has to be thrilled.
Yeah.
It's okay.
Well, people need to be served. This is like a
Yeah,
crisis in our communities. So.
go ahead.
But you had made a request that they provide a written explanation for the 1-year delay. Is that?
We got
We
it.
got it.
Yeah,
You got it
last
last
night.
night, and it should be posted. I asked Alex to post it
It was-
on our webpage.
Okay, thank you.
Yeah, they worked hard on it all yesterday afternoon, so it's a pretty complete.
And are you satisfied with the content?
Yeah,
That was a fast turnaround. That was good.
yeah,
Yeah.
it'll be useful.
4 o'clock this morning. So
Only you would find it at 4.
And as a note, Senators, the memo is posted under yesterday's testimony. I'll add a copy under today's testimony as well for you.
All right, thank you. That's great. Okay. So, Madam Clerk, it's your job to call the roll. And the way we do that is you go to all members and then vice chair and then chair.
Okay, so all members, so I'll start
First,
with with Senator Hardy
Yes.
and Senator Williams
yes.
and Senator Weeks.
now first you go to Senator Gulick.
Oh, okay, yes, I will vote yes. And Senator Weeks.
Yes.
And Chair Lyons.
Yes.
Great, looks like the vote is unanimous, so it's 5 yays and 0 nays, and
So, and then are you willing to report the bill on the floor? Willingness. Willingness.
I'm willing,
Okay.
yes.
And you're able.
Okay,
If you need help, Martina.
Yeah, and there's lots of help around the table and,
We haven't seen many bills yet on the floor.
We
so
all have
that's-
to do it
that- I think-
first time. So
it'll be trial by fire for sure.
I'll talk with you.
Okay,
Okay, so, and Katie, do we have a summary or a statement on the,
Yeah,
Section.
I put a few little bullet points together for the House, so I could send those to Senator Bullock if that's helpful.
Did Teresa, who reported in the House?
Representative Wood reported.
You could also ask her for her report.
Yeah, I think I have a good general understanding of what's gone on and what, but it might be nice, any pertinent details that might come up would be nice.
I'm happy to talk with you at the end of the
Yeah, okay, great.
So I think we're good. We're gonna wrap on time and we're on the floor at 11:30. And Katie, thank you for coming down. I know you're torn
Thanks,
between
Katie.
6 different things.
No problem.
Okay, so we're good. Good for the day. Thanks.
Okay, so
Next, I should, before we go offline, I should share with you that next week, we have a joint meeting with judiciary on a bill about hospital violence and the prevention of hospital violence.
Yeah.
And that meeting is going to be, we're not done yet, and that meeting is going to be on Wednesday, and it's gonna be held over in the Pavilion Building. I don't know what room yet, so I'll let you know as soon as I know.
okay, great.
And then we're also next week going through the bills that are up on our board. That's gonna be a lot of work and just going through and listening in for the first time. Yeah, so
Okay.
that'll be good. That's it.
Thank you,
Okay,
Chair.
thank you.
Ruth, I sent you an
We
email.
can go
in a second.
offline.
You can look at it. That'd be
Yes.
great.
Roger that.